Good afternoon and good morning, good evening, wherever part of the world you are. You're welcome to the webinar on treating uterine fibroids without a knife. My name is Abayomi Ajayi, and it's a very lovely afternoon in Lagos, Nigeria. And we have a wonderful panel today. Before I introduce them, let me tell you that, we have over 1,700 people registered for this webinar. And anytime we're talking about fibroids, you know, people are always very interested from about 28 countries. And we are grateful to our sponsors, Nordica Fertility Centre, Haifu Medical from Chongqing, Hebi from Tübingen, Germany, and the Physician Roundtable. So let me introduce you to the panel today. We will be doing justice to this because we're talking mainly about minimally and non-invasive ways of treating uterine fibroids. The first person I'm going to introduce is Dr. Victor Ajayi. Dr. Victor Dayo Ajayi is a consultant gynecologist and the assistant director at Nordica Fertility Centre. Is a gynecologist and his clinical interests are in endometriosis, polycystic ovarian syndrome, and endoscopy. He's a fellow of the Nigerian Medical College and is a member of the Society of the Obstetrics and Gynecology of Nigeria, as well as the Association for Fertility and Reproductive Health Nigeria. And so it's my pleasure to welcome Dr. Dayo Ajayi to the program today. Hi, Dayo, how are you doing?
Thank you, I'm fine. Thank you for having me.
Great, great, great. I'm sure we're going to have a swell time today. And we already have over 200 people already signed on. Yeah, but the other participant is a very good friend of mine, and he's always willing to talk about his experience, especially in this very interesting aspect of the management of uterine fibroid, which is HIFU. And I'm so excited to introduce to you Dr. Raymond Sedzen. Raymond Sedzen is the director of HIFU Center in South Africa. He's a consultant gynecologist at the Chris Hani Academic Hospital in Joburg. He's the vice president of International Society of Minimally Invasive and Vascular Surgery. And his interest is in gynecological oncology and the surgical management of morbidly adherent placentas, particularly placenta previa. Raymond is a speaker and a trainer in numerous national and international courses, conferences, symposia, meetings, and summits. Raymond, it's always a pleasure to see you, but it's a particular pleasure to welcome you to this webinar this afternoon. How are you doing, Raymond?
Very well, thanks. And thanks very much to you and the organizing committee for inviting me to speak at this webinar.
It's always a pleasure to have you because you always have this so much sought after experience, which we think also we'll be able to gather in Nigeria pretty soon. So without much ado, I think I'll start the ball rolling. This is how this is going to go. I'll just give an overview of what we've been doing in Nigeria concerning this minimally invasive and non-invasive methods of treating fibroids, where we are in trying to join Raymond in the service in the provision of HIFU. And then Dayo will kick off with the minimally invasive method of treating fibroids, which is mainly endoscopic surgery. And then Raymond will tell us about HIFU, which is non-invasive method of treating fibroids. We already have so many questions already that people have passed to us. I hope we'll be able to do justice to some of these questions today in terms of time. But we try as much as we can. But whatever we cannot answer, I'm sure we'll be able to, on the program, we'll be able to take it on and definitely answer all your questions. So I think I'll just start by setting the ball rolling and talking about this condition that is so common, especially among Blacks, which we call uterine fibroids. So my name is Abayomi Ajayi, just like I said, and this is what we're talking about today. this is always a topical issue in the sense that it's the commonest thing that tumor in the reproductive tract, and especially in Black women. And so the term fibroid was first coined by Rokistansky, the Austrian pathologist, in 1860. And we now know them to be benign lumps that grow in and on the uterus. They are the most prevalent benign tumors of the female pelvis. About 70 to 80% of women below 50 years will have fibroids. So it's something that is always, women will at one point or the other come to terms with. And they range in size from seedling that might be even undetectable by the human eye to bulky masses that enlarge and distort the uterus. Well, I like to talk about the size from the point of view of fruits, because that makes it because I know some of the people who are with us are not only doctors. So they can range from very small size, from what we can see on the screen, from 1 to 5, like legumes, up to about larger than 10 cm that becomes like very big fruits, you know. So we can see quite a number of them, and sometimes they can be multiple, or they might just be single. Sometimes it is, especially in this part of the world, it's not unusual to see them expanding so much that they're as big as they can be mistaken for a pregnancy and can even make women to add it. Like we know, they are usually in women of childbearing age, but they can show up at any age. And they tend to be commoner in Black people. We don't really know why this is so, but it seems to be commoner in Blacks. What are the causes of fibroids? We're not very sure yet, but we know that hormones and genetics may play a part. And the search for the gene responsible for the fibroid has been on for quite a while, and the search is still on. But we know that there's some risk factors to this common disorder. Age, the older the woman becomes, the more likely that she will have fibroids. I remember we used to say that the fibroid is the uterus weeping for a baby, that when a woman becomes older and she doesn't have children, that she might have fibroids. And like we said, the race, the Blacks are more predisposed to this. And sometimes also it gets very big in Blacks, much bigger than in the other races. Yeah, and then if you get your period at a very young age, you might also be predisposed to this. There's some studies that have shown that use of birth control pills might also predispose you to fibroids, and being overweight can predispose you to fibroids. Some people have also incriminated diet, that if you eat too much red meat and not enough green vegetables, fruits or dairy, and alcohol. But one thing that we also know very much is the family history, that women who have first-degree relatives with fibroids, that's sisters and mothers who have fibroids, are more predisposed to having fibroids. What are the symptoms? Yeah, it's important to say that many women are without symptoms. So it's not unusual for fibroids to be diagnosed at maybe the annual physical or during antenatal, when you just do a scan and then it's an incidental finding. But for people who have symptoms, this will be between disorder with the menstrual period or pressure symptoms. Now, this disorder with the menstrual period might be that you have heavy menstrual bleeding, or it might be prolonged menstrual bleeding, usually more than 1 week. And then sometimes bleeding in between periods might just also be it. For the pressure symptoms, it's not unusual for people to have pain in the lower abdomen, or they just have a discomfort in the lower abdomen, or you feel that there's a mass in your lower abdomen, or there's frequency in urination, or in difficulty in emptying the bladder, constipation, backache, or even leg pain. Now, when we talk about the types of uterine fibroids. They're usually categorized into about 4 types, 3 main ones, and then the pedunculated. The pedunculated, as you can see from the diagram, is the one that is just loosely hanging by something like a small stalk or a tender stalk hanging on the uterus. So most of the time that can wander around the whole place. And then you have the intramural, which is the one between the muscle layers of the uterus. You have the submucous, which is the one that usually disrupts the lining of the uterus or the endometrium, which is a nightmare to us who are practitioners of IVF, or the one that is also intracavitary, which is a submucous form of fibroid. So, and then you have the subserous, which is outside the uterus. So essentially 3 types, but they can now occur in different fashions. Now, how do we diagnose fibroids? Usually pelvic examination. Many years ago, we used to say fibroids feel fibroids. We know now that imaging techniques are so commonplace, so it's not out of place that ultrasound can be used, MRI can be used, stereosonography can be used, which is like the saline sonography, and of course, hysteroscopy can also be used for us to do this. Now, treatment is where I would just want to dwell a little bit to like an introduction to the other 2 speakers. Yeah, when you want to, it's not every fibroid that should be treated or that needs treatment. So the treatment depends on whether you have symptoms, whether you want to get pregnant, and your age and the location of the fibroid. So these are the things that the physician juggle together to determine what kind of method can be applied, if at all, in the treatment of your fibroids. So what are the options? Yes, like I said, it's not every fibroid you need to treat or operate on. So watchful waiting is one way, okay? Sometimes you have to wait and see, because fibroids are not cancerous and they usually grow slowly. And so, for example, for people who are near menopause, it's not out of place if the symptoms are not really very disturbing to wait for menopause to come in, because we know that majority of the fibroids will shrink after menopause. But we can also use some medications, you know. Analgesics will usually will reduce some form of the pain, and some also reduce bleeding. And then we have the pills, which can reduce bleeding. Then there are other oral drugs now, the GnRH antagonists, the oral form, elagolix has been introduced, newly introduced. Then we've always had the GnRH agonist, Zoladex. And then we now also have some other ones like selective estrogen receptor modulators, who are also already in circulation also. And sometimes also the progesterone releasing intrauterine device also can be used, especially when bleeding is the main problem with the fibroid. Now, one thing that's obvious, especially when we talk about this in this part of the world, is that almost every fibroid, or when we need to treat, the options are really not exhausted in a part of the world, because majority of the time is we just talk about surgery. But one of the things that we want to look at today, especially in this period of COVID, is that we should look at other methods of treating fibroids. And that's why we're really very particular about looking at the minimally invasive and the non-invasive methods of treating fibroids. So we know that the surgery for fibroids, surgery has been the mainstay, especially in many parts of the world. Myomectomy, the first myomectomy that was safe was recorded in 1840, but of course myomectomy has always been, abdominal myomectomy especially, has always been a surgery that is associated with a lot of morbidity and sometimes mortality. Of course, especially a lot of them can also come from anesthetic accidents. But even the history of myomectomy showed that until about 1920, from 1840 to about 1920, when Victor Bonney actually invented the Bonney's clamp, there was a lot of stories about myomectomy being very morbid and associated with a lot of blood loss. Of course, we now know that we can do endoscopic mammectomy. Either you are doing hysteroscopic mammectomy or you're doing laparoscopic mammectomy, which is the main bulk of what Dayo Ajayi will be talking about. And then there's also endometrial ablation. This here, you can use laser, you can use wire loops, you can use boiling water, you can use microwaves, or you can even freeze. The only problem with this is that you don't want to use it for women who still want to have children, because it might just stop them from menstruating by destroying the endometrium. But this is also an option that is open, especially to women who have finished having their children and they are advanced in age. So, and that is one thing that we don't even apply in many parts of Africa. And I think it's one of the things we need to start looking at. We know that hysterectomy is probably the only cure for fibroids, and we can do this abdominally, we can do it vaginally and laparoscopically. You know, we had a webinar sometimes last year on the different approaches to hysterectomy, and we spoke a lot about this, especially the vaginal hysterectomy, which is an art that is dying, which we hope to resuscitate. And we're going to do some other webinars and training on vaginal hysterectomy once this pandemic, either the vaccine comes around in Nigeria and Africa, or the pandemic also rebates. But it's something that we really need to be able to start doing again. But like we said today, we're talking about mainly the minimally invasive. We're talking about the endoscopic methods. I will also mention the uterine artery embolization, which is also available in this part of the world. It's available in Nigeria. But mainly we're going to be talking about the non-invasive today again, which is the HIFU. And you can see on my screen what a HIFU machine looks like. We're so happy that we've been able to get the HIFU company in Chongqing. We've been able to have an agreement with them. And this is on my right on the screen is the person who actually is behind, like the brain behind developing the HIFU machine in Chongqing, China. Professor Wang, and to his left is Professor Rossi. They are very instrumental to making it possible for us to have the machine in Nigeria. I'm happy to tell you that the machine is already at the port, and we probably in a few, by middle of March to the end of March, we should open our doors to start treating fibroids with HIFU in Nigeria. And this, we've agreed on having a fibroid care center, which you're going to be seeing much more about, which is going to be the first in West Africa. I think the picture in Africa is been between Raymond Sazer in South Africa and the guy in Egypt. And so we are going to be the third one in Africa to do that. Well, this was in Chongqing, and this was where finally we started this program now. I'm just going to show you the video showing how you can see the Federal Republic of Nigeria. That's when our HIFU machine was shipped in November last year, and we're going to get it, I'm sure maybe next week or in another couple of weeks in Nigeria. Yes, you can see it was a big program for them to send the machine to us in Nigeria. Well, in order to end my talk, I'd just like to also wish our Chinese friends the happy Chinese New Year. And I thank you for listening. I think I'll just pass the floor over to Dr. Victor Dayo Ajayi to take us through his own presentation. The questions will come at the end of all the presentations. Thank you.
Thank you very much. You've actually made my job easier. My talk was also going to talk about fibroids to introduce it.
Dayo, your voice is muted.
Can you hear me now? Okay. Good afternoon, everyone. It's a pleasure to be talking about fibroids today and the minimally invasive treatment methods. I hope you can all see my screen, which I've shared. The plan is to introduce the topic, talk about the types of fibroids, which I said Dr. Ajayi has done justice to. Then talk about the symptoms briefly, when to treat, and then we'll focus on minimally invasive methods of treatment. I have nothing to declare for this presentation. Yes, we've heard that fibroids are non-cancerous growths. What that means is that they don't usually become cancer, and they originate from the smooth muscle of the womb, of the uterus. Generally speaking, fibroids are seen in the reproductive age group between 15 and 45 years of age. One of the main reasons why women go to see their gynecologist is because of fibroids. Estimates vary. There are different reports that suggest how frequent, how common fibroids are. But generally speaking, about 30 to 70% of women will have fibroids. And there are many women who are just going about their business without knowing they have fibroids. Sometimes it's incidentally that we find the fibroids. They're doing a scan for something else, a pregnancy scan or something, and then we see that there are fibroids. We don't know the cause of fibroids up till now. There are certain risk factors that have been associated with fibroids, which Dr. Ajayi has also mentioned. But one thing we know, incidentally, we practice in sub-Saharan Africa, that Black women are more likely to have fibroids. Some suggest that up to 3 times more likely to have to develop fibroids. Is it genetic? Is it the diet we eat? It's still a mystery, if you like, of why Black women have more fibroids than their Caucasian counterparts or other women from other parts of the world. One risk factor that I like to talk about is age. We see fibroids, as you can see in that slide there. The older the woman gets, the more likely we see fibroids in them. From our own records, the women who present to us present usually at about the age of 38 years. Okay, and that is the age also that you see a lot of fibroids. So we see a lot of fibroids as reported in this study shown on the screen. The other thing we've also noticed, which has also been mentioned earlier, that women who are not conceiving, who are not getting pregnant, are more likely to have fibroids. We are in the infertility profession, and so we see a lot of fibroids because there's an association between infertility and the development of fibroids. In fact, this study we also shown on the screen, we saw that people who had never been pregnant before were more likely to have larger fibroids, and even in numbers, they're more likely to have more fibroids compared to those who have been pregnant before. So obviously, there's a relationship between not conceiving, not having babies, and having fibroids. This also has also been mentioned by Dr. Ajayi, the types of fibroids, which I won't waste too much time on. Symptoms also have been discussed. Sometimes, it's heavy menses with clots of blood. The woman is dizzy. Some people even faint because of the amount of blood that they lose, and this can be due to fibroids. And this is commonly seen with the type of fibroids called the submucous fibroids, the ones that are found inside the cavity of the uterus, of the womb. Sometimes it's painful periods, unbearable painful periods. That can also be due to fibroids. Abdominal pain, feeling pressure in the lower abdomen. Sometimes it's either passing urine frequently, or not being able to pass urine. So it all depends. Sometimes the abdomen is just enlarged, and it can be mistaken for pregnancy. We in this part of the world, we see women who say, I've been pregnant for 5 years, for 6 years, because someone has told them, of course, not the medical people, but the traditional people have told them they are pregnant, and, but it's fibroids in some cases. So, and rarely, it might be infertility. You find women who have fibroids also presenting with infertility. If the fibroid, depending on the location of the fibroid, if the fibroid is blocking the fallopian tubes, of course, that may, affect the chances of conception. Of course, the other thing is miscarriages, especially fibroids that are found inside the uterine cavity. They may disturb any embryo, any baby that wants to grow there. And the next thing is frequent or recurrent miscarriages. So these are some of the symptoms of fibroids. But should we treat all fibroids? Not all fibroids need treatment. There are certain things you need to consider before you decide whether the fibroids should be treated or not. The size is one of these. Generally speaking, the size 4 to 5 centimeters or larger, the fibroids that are in the muscle of the uterus, the one we call intramural fibroids, you may want to consider treatment if they are 4 to 5 centimeters or larger. Location, all fibroids that are inside the cavity of the uterus should be treated, no matter how small, because these fibroids potentially can affect, the chance of getting pregnant. They can, cause miscarriages, and heavy periods also can be associated with this kind of fibroids. Or we are in the IVF business, so sometimes fibroids are in the way of reaching the ovaries where we collect eggs from. Okay, so if this is also noticed at the initial review, we see that, look, the fibroids are after doing a scan, that the fibroids will disturb egg collection. Of course, we will recommend that the fibroids are removed before we continue. Or the fibroids are disturbing the lining of the womb. That's another reason to suggest that those fibroids should be taken care of. If there are symptoms like we've discussed before, heavy bleeding and other symptoms we talked about, or we think there's going to be a problem in future. Sometimes the woman is okay at the point you are seeing her, but if she gets pregnant, the fibroids are likely to get bigger, may get bigger, and may cause problems, pain in pregnancy, or even going back a bit before pregnancy for those doing IVF. When you start the IVF drug, the fibroids may feed on the medications and get bigger, and that could be a problem. So you may want to take care of such fibroids before starting treatment. But if there's no need for treatment, the advice is let the fibroids be. And this is to my colleagues and also patients, because sometimes once you mention there's a fibroid, even if you say it's a 2 centimeter fibroid, the patient is worried, she wants it removed, there are no symptoms, she can't sleep, because she's so worried. Also, medical colleagues also have to know that sometimes the treatment of fibroids may do more harm than good. So it might be better to let fibroids that are not causing problems remain and just observe the woman. So what are the treatment options? The traditional method is apart from the medical treatment, which Dr. Ajayi had spoken about, the surgical method, the traditional one, is the open myomectomy, to open up the woman to remove the fibroids. Today we want to talk about less invasive ones. There are problems that can arise with open myomectomy. We, especially in IVF practice, we see a lot of patients who have had open myomectomy and have some issues, which maybe not categorically, we can't categorically say so, but may have been related to previous open myomectomy. Sometimes these surgeries can damage the fallopian tubes, which is important for conception, for natural conception. Sometimes the womb, the inside of the uterus, may be scarred from the previous operations. And this can affect implantation when you put embryos inside the womb and can lead to IVF failures. Miscarriages can also happen, problems with bleeding in pregnancy. And sometimes because of this so much scarring of the inside of the womb, we may have to suggest that the woman does surrogacy. That means someone else carried the pregnancy if the inside of our womb is adjudged not suitable to carry that pregnancy. We published this study, and where we looked at we did hysteroscopy in over 900 patients, and we saw the majority of them, about 61% of them, had problems in the uterine cavity. And one of the leading problems was scars inside the uterus. And when we tried to see what did they do before presentation, part of the thing include open fibroid surgery, D&C, cesarean section. But when we compared those who had these scars versus those who didn't have scars inside their womb, we saw that those who had scars were about 2.5 times more likely to have had an open myomectomy. Okay, so this could be a risk factor with developing scars inside the womb. Now, to the topic of the day, the main topic of the day, minimally invasive methods for treating fibroids. I'm going to be talking about laparoscopy in the next few minutes. Basically, it's keyhole surgery. What that means is that you can use the analogy of looking at the inside of a room, looking through the keyhole. You don't have to get into the room to see the inside, the whole picture of the inside of the room, in this case, this analogy. So laparoscopy is similar. You want to see inside the abdominal cavity and even operate and remove fibroids without going in directly. Another way to look at it is like you're using longer hands to operate, from outside the body. So that picture is showing what laparoscopy is all about, and you can use that to remove fibroids. So just few cuts are made in the abdomen, 1 to 1.5 centimeters. And then through there, you can have access to the inside of the abdomen, look at these fibroids, identify them, and actually operate on them and bring them out of the body. How do we take these fibroids out? Because you may be wondering that this 4, 5, 6, 10 centimeter fibroid, how does it come out from the small incision we talked about? So there's what we call mucilation. Okay, there's a special instrument that does that, where the fibroids are shredded into, you can see the picture to my right that shows how the fibroids are shredded using this machine to make it easier to pull them out of the abdominal cavity. So that's how do we close the wound? That's another thing that gives laparoscopic myomectomy an advantage. I'm going to show some of the benefits of laparoscopic myomectomy shortly. But even the wound closure, the skin wound closure, we use a special glue, really, to close the skin wound. And so if you look at the picture also to my right, compared to when you use staples or you use stitches, you can see how fine the wound that has been closed with Dermabond is called, has come out compared to when you use stitches. Again, look at these pictures also. If you compare the laparoscopic myomectomy, which is a minimally invasive method we're talking about, you can hardly see any scars on the patient to my far left, you can hardly see any scars left behind, compared to the last other two pictures where the women have had open myomectomy done. So that's one of the advantages of laparoscopic myomectomy. We've done over 100 cases so far and counting. And the benefits, like we've already started talking about, is that it's minimally invasive, there's less scarring, and this we demonstrated in this report we did on our patients. So it's not hearsay. We have figures to show this, that there's less scarring, it's more cosmetically acceptable, shorter hospital stay. Our patients go home in 72 hours, they're home, quick return to normal activity. There's less blood loss, mostly no need for blood transfusion. Generally speaking, there are fewer complications. But of course, there are possible drawbacks to laparoscopic myomectomy. It may take a bit longer than open surgery in some cases. But then occasionally you have need to convert or to do a laparoscopic assisted abdominal myomectomy. This is not so frequent. 1 in 20 is the estimate for this, and maybe technically demanding. So it's not for everyone. It has to be someone who is well trained in this procedure. Traditionally, we use GnRH agonists to shrink the fibroids because that may help to make them smaller and then make the procedure easier. So we usually do this for 3 months to shrink the fibroids. The common drug we use is Zoladex, and that can help to shrink the fibroids and make the procedure easier. Then the sister procedure to laparoscopic myomectomy is called hysteroscopic myomectomy. So in this case, we're talking about fibroids that are inside the uterine cavity. So we have an approach to this. In this case, there are no cuts at all. Okay, you don't need to be cut open at all. Not even a small one. Any incision is necessary. We found in our patients about 15% of them had this kind of fibroids that are mainly inside the uterine cavity. And like I said, basically no cuts. The same day discharge. So it's a day case. You go home the same day, and of course fewer complications. The scarring of the inside of the womb is less likely to happen with hysteroscopic myomectomy compared to open surgeries. Dr. Raymond is going to be talking about actually non-invasive, completely non-invasive method of dealing with fibroids called the high-intensity focused ultrasound. So we are moving from open surgeries to minimally invasive, and then now we're going to be having non-invasive, completely non-invasive. So I'm sure that that's going to be a very interesting topic. I'm sure Raymond will do justice to that. The thing to note with this kind of procedures, both the minimally invasive and the non-invasive, is that patient selection is key. Okay, so you have to look at the patients that are right for these procedures. Size will matter, size of the fibroids, the number of fibroids. So you need to, be able to estimate the number of fibroids that the patient has, either by ultrasound or MRI, and that would be a guide on the, whether the patient is suitable to have any of these procedures I mentioned. People have had previous open myomectomies, fibroid surgeries, may not be qualified after our evaluation, depending on what our review says. And then, of course, it should be for trained hands, like I'd mentioned earlier. So I will conclude this discussion by saying that fibroids are common among women. In fact, they are said to be the commonest non-cancer tumors in women of reproductive age group. So we see them all the time, especially in Black Africa. And sometimes they cause no problems. Sometimes they cause problems, symptoms that we've talked about, and therefore may need treatment. So the emphasis is, when possible, the attempt should be towards minimally invasive or non-invasive methods for best outcomes. Thank you for listening to this presentation.
Yeah. Thank you so much.
Should just check on in the meantime.
Thank you so much, Dayo. Wonderful presentation. Yes, like I said, we take the questions at the end of the talk. And then, yes, I just want to mention that Dr. Stewart Disu is signed on here. Stewart is one of our very good surgeons, and he does a lot of laparoscopic myomectomy. So, yes, I think we just go on to tell Dr. Raymond Setze to give us his paper. Raymond, the floor is yours.
Thank you. Can you see the presentation?
Yes. Same.
Okay. Okay, good afternoon, ladies and gentlemen. And Dr. Ajayi, thanks once again for inviting me to present at this webinar. I'm going to be speaking about HIFU, which is a high-intensity focused ultrasound. I work at Chris Hani Baragwanath Academic Hospital, which is situated in Soweto in South Africa, and it's the 4th largest hospital in the world. So we see a lot of fibroids. Just trying to get my slides to move. So if we look at the development of fibroid treatment over time, initially we started off with very invasive procedures where we did open laparotomies, where either a hysterectomy or myomectomy was performed with the chance of causing problems for the patient. As our surgical techniques improved, we then went on to slightly less invasive procedures like vaginal hysterectomies. With the development of laparoscopic equipment, we went on to minimally invasive procedures where we do, as Dr. Victor told us, laparoscopic myomectomies, hysterectomies, hysteroscopy, and including uterine artery embolization. And now we've got a completely non-invasive procedure, which is based on ultrasound imaging, and that is HIFU. Now, HIFU has been around for quite a while. It's been around since 1999, and it's practiced in more than 26 countries around the world. In China alone, there's more than 150 HIFU centers. So now we've got in Africa, South Africa was the first one to get a machine, followed by Egypt, and now Nigeria is going to have the 3rd machine. What is the principle of HIFU treatment? How does HIFU treatment work? What happens is we have a ceramic concave transducer which produces high intensity ultrasound waves. And these, because the transducer is concave in shape, it focuses all the ultrasound waves to a focal point, which is about 12 centimeters from the transducer. Now at this focal point, the mechanical energy of the ultrasound waves is converted into thermal energy, and we get heat produced at this focal point. This focal point is then directed into the fibroids, and we keep on depositing this thermal energy into the fibroids. When the temperature reaches in excess of 56 degrees Celsius, we get protein denaturation, where therefore we get coagulation, necrosis, and cell death. It's similar to working with collecting the rays of the sun with a magnifying glass. So on the area where the rays are converging, there's minimal energy or heat in that area. So if you put your finger anywhere along here, you're not going to burn yourself. But when you put your finger or you put a leaf or a piece of paper at that focal point, it's going to burn. So that's basically how HIFU is working. Now, what are the mechanisms of tissue damage? How does HIFU destroy the fibroids? So as we mentioned already now, we've got conversion of mechanical energy, which are the ultrasound waves.
Hello, Raymond.
Yeah?
Please, can you increase your volume?
Can we increase the volume? No, I'm at the maximum. I'll try to talk louder. Is that better?
Yep.
Okay, so as I said, we've already mentioned the conversion of mechanical energy, which are the ultrasound waves, into thermal energy. And as we said, we'll get immediate thermal toxicity once the temperature rises above 56 degrees Celsius. The other way that we get tissue damage is a process called inertial cavitation. So what happens is, as the ultrasound waves are passing through the tissue, we get alternating cycles of compression and rarefaction or decompression. I'll show you a diagram so you can see how this works. During the rarefaction part of the cycle, gas bubbles are drawn out of solution. These will fluctuate in size, and eventually, as they get bigger and bigger, they will eventually collapse, releasing energy, and this adds to the temperature increase. So here you can see, this is the plane, the path of the ultrasound wave. Here you can see compression followed by rarefaction, okay, as it's going through the tissue. And then here you can see the change in the bubble size. So the bubbles get bigger, smaller, bigger, until eventually they get so big that they rupture, releasing energy, which is equated to temperature. So if we have a look over here, we can see here we've got the skin surface. Let me just go back one. The transducer will be up against the skin here. This is our what we call the acoustic pathway. That is our focal point, which we've directed into the center of the fibroid. So our energy is going to be deposited into the fibroid. Along this pathway here, any structure that's within this pathway is going to be undamaged. So effectively, what happens is we selectively destroying tissue at depth without harming overlying adjacent structures within the path of the beam. So if we look at the skin appearance after our different kinds of treatment, okay, here we've got laparotomy, got a nice scar there. Laparoscopy, smaller scars. If you look at HIFU, the skin is completely untouched. There's no marks at all. If we look at the appearance of the uterus following our different treatments, on the left here, we can see what the uterus looks like after laparoscopic myomectomy. This is what the uterus will look like after HIFU. So what is the scope of HIFU? HIFU is used to treat benign and malignant solid tumors, including prostate cancer, liver cancer, breast cancer. With pancreatic cancers, it's used mainly for pain control, not for cure. It's used in bone cancers, renal cancers, but in gynecology, it's only used for benign conditions. And the main ones are uterine fibroids and adenomyosis, but it's also used for treating, there's literature now for treating placenta accreta syndromes and for cesarean scar pregnancies. This is the machine that we are using. It's a model JC200. The company that you can see at the top there is HIFU. There's an A in it there, which is different, that indicates the company. They're situated in Chongqing, China. They were the inventors of HIFU. And this is a machine that we are using, the JC200. Now with HIFU, you get MRI guided HIFU and you get ultrasound guided HIFU. We use ultrasound guided HIFU. I'm not going to go through the equipment, but I just want to show you this part of the machine. This is the most important part. It's called the combined treatment head. So what happens is here you've got your concave transducer that produces the ultrasound beams for the treatment. And in the center over here, we've got a normal beam mode ultrasound, okay? And this is how we isolate and find the fibroids. Now, what about patient selection? So we are basically treating patients with symptomatic fibroids and adenomyosis. So patients with menorrhagia, anemia, a big problem. A lot of our patients are requiring repeat transfusions, iron infusions, dysmenorrhea, infertility or poor obstetric history, obviously if it's related to multifibroid uterus. And the other big problem we see is pressure symptoms. So patients with big fibroids causing constipation, urinary frequency, nocturia, or even difficulty passing urine. Also, we have a lot of our patients are desiring fertility and they want to preserve the uterus. They don't want to have a hysterectomy. And again, a lot of patients are refusing surgery. They refuse myomectomy because if they sign for myomectomy, they have to sign for hysterectomy in case we have to do an emergency hysterectomy because we cannot stop bleeding or we cannot close the uterus. And also patients refusing blood products. So if she's got a big fibroid uterus, that could be a problem. The patient criteria, so they shouldn't be obese. Obesity is a big problem, especially if the abdominal wall thickness is greater than 6 centimeters. Number one, it's going to be difficult to identify the fibroids. It's going to be difficult to treat the fibroids, and there's a big chance we can get skin burns. We are going up to a uterine size of about 18 weeks, which is a lot bigger than most places are doing. You must be able to see the fibroid. So if it's a small fibroid, less than 2 centimeters in diameter, and you can't see it adequately, you shouldn't treat it. And then obviously the patient should have a normal pap smear. If they've got any pre-malignant condition, then maybe they would do better with a hysterectomy. If they've got an intrauterine device, it should be removed before treatment. We cannot do it on pregnant or lactating patients. They should be in good general health. There should be no big scars on the abdomen, on the area where our ultrasound beam is going to be. Number one, because it will decrease the resolution behind the scar, and also there's an increased chance that the patient can get skin burns. Another thing is the patients must be able to lie prone for more than 2 hours without moving. So if the patient can't lie still, then obviously it's going to be a problem. They have to be able to lie still for in excess of 2 hours. And also you should be able to communicate with the patient. If the patient doesn't understand your language and you can't communicate with her, you shouldn't do the treatment. Now, what about exclusion criteria? Obviously, we can't do this on all patients. As I mentioned before, obesity is our number one problem. If the abdominal wall thickness is greater than 6 centimeters or the BMI is greater than 30, then they're not good candidates. Uterine size greater than 18 weeks. If they've got abdominal scars, and also if there's multiple fibroids. If they've got 10 or 12 fibroids, it's not going to be a good candidate. So there's a typical example of some of the patients that come to us. You can see she's obese. That abdominal wall thickness is going to be greater than 6 centimeters, and she's got a terrible scar on her abdomen, which is going to cause problems. So which fibroids? Obviously, we can't, as I said, we can't treat all fibroids. So we can't treat hyperintense fibroids, which are very vascular fibroids, because we need to build up the temperature to greater than 56 degrees Celsius. So if the fibroid is very vascular, as you are depositing your energy, the heat is going to dissipate out as the blood flows through the fibroids. So if they're very vascular on MRI, we won't treat them. We can't treat pedunculated fibroids either, especially if they've got a thin stalk, because what can happen is the fibroid can dislodge from the uterus, fall into the pelvic cavity, and cause problems for the patient. Also, fibroids that are inside the uterine cavity, if they're completely inside the cavity, we won't treat those either because we can damage the endometrial lining. You remember when we deposit heat into the fibroid, heat dissipates. It's not going to sit in one spot. It's going to move. So if you get close to the border of the fibroid, you could land up damaging endometrium and land up with the Asherman's type of syndrome. So we won't treat those ones either. Now, just quickly, I'm not going to go through the whole procedure because it's quite extensive. The important thing to know is that the patients lie prone, and we position them in such a way that the pelvis and the uterus is overlying the transducer. This procedure is done under conscious sedation. The patients have to be awake because they need to tell us what they're experiencing. because if too much heat on the skin surface, they can get burning, so they will warn us that the skin's getting hot. Or if we get too close to the pelvic sidewall, we could get heat radiating to the pelvic nerves. We could land up with a permanent foot drop, something like that. So the patients need to be awake, so it's done under conscious sedation. We then locate the fibroids using the ultrasound part of the treatment head. And then once we see the fibroids, we put our focal point into the center of the fibroid. That's our acoustic pathway. So there you can see the uterus with the fibroid, that's the bladder. And then what we'll do is we'll start depositing energy, ultrasound waves, into that fibroid. And we do this until we get grayscale change. So this is what it will look like. So here we go, we're giving energy. And once we get coagulation necrosis, we start seeing what we call grayscale change. So that's how we monitor what's happening. So we move the focal point around in the uterus until we have ablated probably about 80% of the fibroid. So how do we monitor treatment? How do we know how we're doing on the treatment? Are we under-treating? Are we over-treating? Obviously, if we over-treat, it's dangerous as well because we're depositing a lot of energy into the abdomen. So one thing we do is we look at the grayscale change. So as we said, the tissue becomes white once you get coagulation necrosis. So we monitor to see that more than 80% of that fibroid has undergone grayscale change. The other thing that we do is, if you look at the picture on the bottom there, is we do Doppler, color Doppler. So we'll put the Doppler on beforehand and we'll see the blood flow. And then again, we'll put it on when we think we've completed the treatment. And at that stage, there should be no blood flow in the fibroid. We should have ablated all the blood vessels. What they also do overseas, unfortunately, it's too expensive for us to do in South Africa, is they use microbubbles. And what this is, it's a contrast medium, which is placed into tiny little nanospheres. This is injected before treatment, and then you'll see what the uterus looks like with the fibroid, what the fibroid looks like. And then when you think you've finished the treatment, you'll inject it again, and then you should see something like that. So here you can see the very vascular fibroid before treatment, and that's what it should look like post-treatment, where you've ablated all the vasculature, and then you should have no contrast inside the uterus, inside the fibroid. So complications, as with any procedure, you can get complications. The main problem is pain. Now, this is during the treatment. It's transient, it's usually mild, short-lived, and the anesthetists manage it with analgesia. So at the treatment site, inside the fibroid, it's normal. You're causing ischemia in that fibroid. So the patients will complain of a dysmenorrhea kind of a pain, which is normal. Pain in the back or the buttocks, and that's mainly with posterior fibroids, where the heat is dissipating and moving towards the spinal column. Again, it's normal, but you need to make sure if they're complaining the whole time, you need to take special precautions. Pain in the legs is dangerous because now we are looking at getting nerve damage. So that one we're very worried about, pain in the legs. Skin toxicity is another problem. If you do, even though I showed you in the beginning that there's minimal energy in the acoustic pathway, the area between the transducer and the focal point, there is still some energy there, and you can get increased temperature on the skin surface, which can lead to skin burns, blisters and burns. Bowel injury is another problem. Anything that's got air inside is a problem for the ultrasound waves. It will deflect the ultrasound waves, and it can cause damage. So if we've got bowel in our acoustic pathway, we need to get that bowel out of the way. If we can't get it out of the way, we won't be able to do the treatment. So if you do get bowel coming into your field, you can land up with a perforation of the bowel. You can get bladder injury as well if you're depositing too much energy near the surface of the bladder. As I mentioned before as well, if you treating a fibroid that's very close to the endometrial surface or inside the cavity, then you can get damage to the endometrium, which can land up with the Asherman's type syndrome. What are the advantages of this procedure? Well, it's a day procedure. The patients come in the morning, they have the procedure, they go home the same day. Because it's totally non-invasive, we've got sparing of the uterus. We never land up having to do a hysterectomy for these patients. And because of the precise ablation to the target area, we do not affect the normal uterine tissue. So the myometrium is left completely intact. So patients who fall pregnant after HIFU can have vaginal deliveries. It's not a problem. It's not like a myomectomy where you've got damage to the myometrium and you would need to do a cesarean section. There's no general anesthetic, so the patients recover quickly. The recovery period is faster. They return to work. We give them a week off. In China, they go back to work usually within about 2-3 days. There's no ionizing radiation at all. So this procedure can be repeated. If you've got multiple fibroids, then it often becomes an issue that you can't do all the fibroids at one sitting. So we can do maybe, say, 6 or 7 fibroids at one sitting, bring the patient back again in 3 months' time. So you can repeat it as often as you want. There's no radiation. And obviously, because it's such a target-directed procedure, there's no damage to the ovaries. It's cost-effective, decreased hospital stay, no blood transfusions are required. We have quite a high HIV situation in South Africa. Probably about 25% of our females are positive in the reproductive age. So again, if you're doing myomectomy or hysterectomy on big fibroids, there's a chance that someone can get pricked or cut. With HIFU, there's no problem with that. And in general, it's very safe, low risk of complications. Just to look at the estimated recovery time with these different procedures. With the HIFU, it's 1 to 2 days. In South Africa, hysterectomy, they get 4 to 6 weeks recovery time. Same with the open myomectomy. Laparoscopic procedures, they get 2 to 3 weeks. Uterine artery embolization, they get 1 to 2 weeks recovery time. Now, obviously, there's disadvantages and limitations. As I said before, the acoustic path cannot penetrate anything that's got air in it. So for us, bowel is a problem. Limited accessibility, dependent on the position of the fibroid. If she's got a posterior fibroid and it's a fat patient with a thick abdominal wall, we might not be able to reach it. If our focal, remember our focal length is only 12 centimeters. And depending on where the fibroid is situated, if it's very close to important structures, it might be too dangerous to treat. It's a lengthy procedure. I mean, if you take a 10 centimeter fibroid, if you were doing a myomectomy, it would probably take you about 20 minutes. This HIFU can take you about 2 hours to do a 10 centimeter fibroid. And then obviously, we can't remove small little fibroids if they're not visible, which you might be able to remove at a myomectomy. Factors affecting the recurrence of fibroid growth. If the fibroid is greater than 6 centimeters in diameter, there's a chance that it might continue to grow. If they're very vascular, as we mentioned before. If it's the non-perfused volume, that is the amount of the fibroid that on MRI the next day has been ablated. So if that's less than 60%, if it's only killed off less than 60% of the fibroid, there's a good chance it can continue to grow. Just to quickly go through our results in South Africa, we've treated 460 patients now. They've all been Black females. I'm not going to go through too much detail here because we're running out of time. Most of the fibroids have been intramural. Most of them have been hypo. So when we decide on which patients we're going to treat, we do an MRI and we look at the T2 signal intensity. If they hypo, which means that the fibroid appears black compared to the surrounding myometrium, then those are good candidates. So the majority of our patients were hypointense. The symptoms, as we mentioned before, dysmenorrhea, menorrhagia, anemia, infertility, constipation, frequency. These are the common symptoms that our patients present with. Adverse events during the treatment. So most of the patients will have some abdominal pain. That is the commonest thing. 51% of the patients that we've treated had pain in the buttocks or in the lower back. 31% had burning sensation on the skin, and 14% had transient leg pain. If we look at the major adverse events post-treatment, of the 460 patients, we only had 2 cases of first-degree burns of the skin, which resolved spontaneously within a couple of weeks. They didn't need grafting or any other further treatment. We've had no bowel injuries. We've had no bladder injuries. We had 2 cases of nerve injury that also resolved spontaneously within a couple of weeks. So we've had no major adverse events. All our patients fill in a form. It's a health-related quality of life score. This chart over here, if you look at it, gives you the quality of life of the patients. So if you look before treatment, the score was low, around about 35. And within 1 month already after treatment, it had gone up to about 55, and then slowly increasing until 24. We follow them up to 2 years post-treatment. At 24 months, the score had risen to about 75. So there's a marked improvement in the quality of life. This chart over here shows you the symptom severity score. So before treatment, they had a high score, just below 60, so marked symptoms. And then you can see how 1 month, 3 months, going down to 24 months, how the severity score decreased. So there's a marked improvement in symptom score. If we look at the shrinkage rate of our patients, at 1 month, it was about a 31% shrink in the fibroids. At 3 months, it's gone up to 52, 61 at 6 months, and 73 at 12 months. In terms of fertility successes, we've had 16 cases. 8 patients are currently pregnant. We've had 1 4-kilogram vaginal delivery, and we've had 7-term cesarean deliveries. Now, the problem also with our patients is, like, once they fall pregnant, once they conceive, a lot of the time they don't come back to us. They go to their private doctors, so we don't even get to hear about them. This is just a gallery of our patients, some of our patients and the babies that we've delivered. Just to show you some pictures of what happens. I'm going to go through this quickly because we're running out of time. This is before treatment. You can see the big fibroid over there. And then this is post-treatment. This is at 2 weeks post-treatment. This is what we talk about, the non-perfused volume. You can see it's completely ablated. There's no blood flow in there. That's a fibroid at 4.5 months. That's at 10 months. There again, you can see how the fibroid in this patient over here, this was quite a big fibroid there, and how it shrunk. And at 12 months, it's gone. The fibroid has disappeared. There again, just some pictures to show you. These are patients that we've treated. So here's the fibroid pre-treatment. This is after 1.5 months. That's the MRI showing you the fibroid completely ablated. There again, you can see the fibroid over there. Pre-treatment at 4 months. You can see it's already shrinking and completely ablated. There's another slide. Here the patient had 3 big fibroids. There's one up there, another one over there, another one over there. Pre-treatment, there you can see afterwards how the majority of the fibroids have been ablated. There's just another one. So in conclusion, HIFU provides a safe and effective alternative in our management of patients with symptomatic fibroids. Thank you for your time.
Yes, thank you so much, Raymond. It's been wonderful listening to you once again. I think, yes, I have an announcement for the doctors before we go to the questions. In previous webinars, we always have a problem in giving you your CME points because majority of you don't sign in with your real names, and therefore it becomes very difficult to know who actually participated in the webinar. So please, if you have not signed in with your real name, you can either rename yourself or send us a message, and those joining on Facebook should send a mail with their full details so that we can give you your points. Now, I think we just go straight to the questions. I don't actually know where to start from because there are many of them. But maybe I'll start from the people that send their questions even before the webinar started. There are a lot of questions even from the doctors, and I'll pick a few of them. I think you have already answered this first one. After HIFU, can I still do IVF and get pregnant? I'm 49 years old. I think you want to say that. I know you answered that in your presentation, but Raymond, you want to say anything about that?
So what's the question? Can you have IVF post-treatment?
Yeah.
Yeah, so as I mentioned before, the treatment is target directed. It's only the fibroid that has been treated. So what will happen is once that fibroid, what happens is after it's been ablated, with time, it can take a couple of months, that fibroid will shrink in size. So you've got no damage to the ovaries, you've got no damage to the tubes, you've got no damage to normal myometrium. So the patients can definitely have IVF post HIFU treatment.
Great. This is another question. Can someone who has had surgery done before use HIFU, still do HIFU?
Sorry, what was the question?
Can someone who has had surgery done, a myomectomy done before now, can she still do HIFU?
Yeah, we've had a lot of patients who've had previous myomectomies who've come for HIFU. The problem there is, as we know, with myomectomies, there's an increased risk of developing adhesions. And as I mentioned before, if we can't get bowel out of the way, if we've got bowel stuck onto the uterus and we can't get it out of the way of our acoustic pathway, we won't be able to treat. But if we can get the bowel out of the way and there's no adhesions, yeah, we can treat post myomectomy.
Then another one says, okay, I think the major off for me is the time it takes for the procedure. You also can't have tissue samples for histology. What do you say to that?
Yeah, no, unfortunately, there's no histology. So that's why you have to be very careful in interpreting the MRI and make sure you don't have a leiomyosarcoma. We're doing it in younger patients. At the moment, we're doing it up to patients of age 45. And to date, I must say, we haven't picked up any leiomyosarcomas. But yeah, you don't have histology. And unfortunately, the procedure does take quite a long time.
Okay. There are a lot of patients talking about reproduction and IVF with HIFU. I think majority of them you've answered. I'm a perimenopausal, I think that we have to do this. I'm a perimenopausal woman with large fibroids. What are my chances of having a successful IVF?
We usually would have to evaluate you. Like we said, fibroids may not affect your chances of conception. So what we do is where the fibroid located and all that. If it's outside the womb, the intramural or subserous one, most times there's no problem. If, from what you've said, perimenopausal, if we think that you should be using donor eggs, then that's not going to be a concern. We recommend a hysteroscopy or a cavity check. Once the cavity is fine, then we can proceed. However, if you are going to use your eggs, if we do an evaluation and you're going to use your eggs, if the fibroids are in the way of collecting the eggs, we may have to ask you to take out the fibroids before we proceed. So everything will depend on the evaluation of you and your partner, and then we'll advise appropriately.
Okay. I think the next one, I've done fibroids twice. The last one was done in the month of August 2018, but yet to be pregnant and no child for now. It has started growing again. I need help to put an end to it forever. Thanks.
Well, it depends on, you have to choose one thing you want to focus on. Fibroids is not necessarily the cause of your not conceiving. Many people make that, take that as what is causing infertility. You have to be evaluated. It takes your eggs, it takes your partner's sperms, the state of the inside of your womb for pregnancy to occur, your fallopian tubes and all that. So New fibroids can grow after you've had surgery before. So what I would advise is that also be evaluated for fertility. Let's know what the problem is, and then we can advise. If we think the fibroid is a factor that needs to be taken care of, we will advise. And then saying that you want to take care of fibroids forever, well, except you want to have a hysterectomy, that's the cause, that's the cure for fibroids. But seeing that you also want babies, you know, it's not something that one would recommend as first line. So I would advise you have an evaluation done for fertility, and then we can advise appropriately.
Is it possible that she actually has adenomyosis and not fibroids?
It's possible, and that's what the evaluation will do, to tell us exactly what it is, because you're right, there's sometimes a misdiagnosis of fibroids and adenomyosis, yes.
Okay. To Raymond, can this procedure be used to remove any type of fibroid, no matter the location? I think you've already answered that.
Yeah, so we can't do pedunculated fibroids, and we can't do intracavitary fibroids. Those are the main ones that we can't do.
Is there a specified time of waiting after the procedure before one can start trying to conceive? That's after HIFU. Yeah,
the recommended time is about 6 months. So what happens is after the HIFU, that fibroid becomes necrotic. So you want most of that necrotic tissue to be resolved before you start trying to conceive. So the recommended time is 6 months.
Okay, another one, how long does this procedure take? Can one go home the same day after the procedure?
Yeah. So
there are many questions loaded together. Would there be a repeat of the process? How does the fibroid leave the body after the procedure?
So how does the fibroid leave the body? So it doesn't leave the body, it stays inside the uterine wall. And due to inflammatory reactions, it slowly gets resorbed with time. So it's not like doing a myomectomy where you've removed the fibroid. All we've done is we've ablated the fibroid, we've basically killed off that fibroid, and then with time it will be resorbed. The time, how long it takes to do the procedure, depends on how big the fibroid is and how many fibroids you're treating. If we're treating, say, one single 5 centimeter fibroid, it may take half an hour. If we're treating 2 10 centimeter fibroids, it might take 2 to 3 hours. And yeah, sometimes if there are too many fibroids or the procedure is going on for too long, we'll bring the patient back for a repeat treatment. Or if we find that the fibroid is still growing post-treatment, we can repeat the treatment on that fibroid.
Can one go home that same day?
Yeah, our patients go home, they come in and go home the same day.
Great. Okay, everybody is asking about the cost. I want to come to that later on. Okay, I think some of them you have already answered here. Okay. Sorry. Okay. Okay, I think you've answered this again. Somebody, what's the recommended conception time? What is your take on CS myomectomy? Okay, what is your take on, do you advise that someone does cesarean section myomectomy?
If you're talking to me, no. It's too vascular to do. We don't do myomectomies at the time of a cesarean section. Unless it's a pedunculated fibroid and you can easily tie off the stalk. But if you're going to start digging into the myometrium, we don't recommend it. We don't do it. Victor, I don't know what Victor.
Yeah, right. I agree, because you can have uncontrollable bleeding, and that can increase morbidity and for the patient. So you could do it as an interval procedure. Except if you have the easy ones, the pedunculated one, like you rightly said. So I also would not advise a cesarean myomectomy.
Yeah, coincidentally, I read a report yesterday, a paper about somebody talking about and concluding that it's possible to do cesarean myomectomy. Yes, I think I agree with all of the two of you that as much as possible, one should avoid cesarean mammectomy. Yes. One of the contraindications for HIFU is multiple fibroids. Unfortunately, most of our fibroids in Africa always come in multiples. Is HIFU still not possible? I think you answered during your presentation, but go on.
Look, it is possible, but you're going to need multiple sittings. Now, we do the same when we do myomectomies. If a patient has got too many fibroids and you've got a sort of uncontrolled bleeding, or you're worried that you're not going to be able to close the uterus, then even at a myomectomy, we'll take out maybe 10 or 12 fibroids and then have a repeat sitting maybe 3 to 6 months later where we'll take out another 10 or 15. So the same happens with the HIFU. We can only treat maybe 4 or 5, maybe 6 fibroids. So the problem is most of our patients that are coming to us come at a late stage. They come when they're 38 or 40 years old, and there's not much time left for them to, if they want to conceive. So if we have to treat them and then bring them back again in 6 months and then bring them back again in 6 months, we're wasting a lot of time. So those patients, we would rather recommend they go for myomectomy.
Okay, great. Okay, we have quite a number. Okay, can someone with adhesions, frozen pelvis, and fibroid do HIFU?
Yeah, they can, as long as there's no bowel in front of the pathway. So even though the uterus is frozen, so that's one of our indications of doing HIFU as opposed to a myomectomy or a hysterectomy. Patients with a frozen pelvis, as long as we don't have bowel stuck in the way of the acoustic pathway.
Great. Now, this is a question about adenomyosis. What is the effect of HIFU on adenomyotic tissue?
So HIFU, one of the indications for HIFU is adenomyosis. Obviously, it's a lot more difficult to treat because with the fibroid, you've got a very precise picture. You can see exactly where the fibroid is. You've got a pseudocapsule around it. Whereas with the adenomyosis, it's more diffuse. It's not well circumscribed like a fibroid. So it's a lot more difficult to treat adenomyosis, but yes, adenomyosis is one of the main indications for HIFU.
Thank you.
We can't treat endometriosis though.
Yeah. Okay. You have quite a... Yeah. Why I'm skipping some is that you've already answered them. So, okay, somebody's asking about adenomyosis again, which you have done. What is the risk of recurrence after successful HIFU? I think we mentioned about it. Please, can we just do that?
The problem with recurrence afterwards is it recurrence in that fibroid or are the patients growing new fibroids? So we can see on the MRI a lot of the time that there's tiny seedlings. We'll see small little fibroids throughout the uterine wall. Now, are those new fibroids that have grown, or is it the fibroids that you've treated that are regrowing? So sometimes it's difficult to tell. But if you've achieved greater than 60% non-perfused volume in that fibroid, you shouldn't get regrowth of that fibroid.
What is the worst complication your center has encountered managing patients with HIFU? And how did you manage that complication?
So we've just had, as I mentioned, we've only had 2 superficial first-degree skin burns, which were just treated with dressings. And then we had 2 patients with pain in the leg, and that responded to prednisone and Lyrica. And so we've had no major complications. We've had no bowel injuries. We've had no bladder injuries. Now, again, if you're treating patients with big multiple fibroids or patients with adhesions and all that, when you're doing your surgery, there's a very high complication rate of injuring the bowel, injuring the bladder. So we've had nothing. We've had 2 superficial skin burns. 2 patients with leg pain, which resolved spontaneously. So it's a very safe procedure.
Okay, great. Yeah, this is a very interesting question. I've done I'm sure this is a doctor. I've done a myomectomy during a cesarean section because it was lying on the lower segment of the uterus. Question is, can this ultrasound procedure, that is HIFU, be done with pregnancy in situ if it is expected to affect the operative morbidity?
No. One of the contraindications is we can't do it on pregnant patients. The problem is that the temperature in the fibroid can range from anywhere between 56 to 100 degrees Celsius, and heat dissipates. So the problem is that you could land up getting heat transfer across to the baby, the placenta, the cord. So one of the contraindications for HIFU is pregnancy. You wouldn't do it in a pregnant person.
Well, you answered this last one too. Can someone use this for endometriosis? I think that has also been answered. We have quite a number of questions, but majority of them are just interwoven.
The endometriosis, the one endometriosis that we can treat is an endometrioma in the abdominal wall, because that's localized. That we can treat, but we can't treat pelvic endometriosis.
Yeah. Yes, maybe I should just say this, that, okay, we're not saying that HIFU should be used for every fibroid. We're saying that HIFU is another option that you can consider as part of the things that you can use to treat fibroids. So, and that's what Raymond has been trying to say. You have to select the patients that you think are best for HIFU. Submucous fibroids, the best way to treat submucous fibroids will still remain the stereoscopic myomectomy. Okay, so that's because I see a lot of questions here about submucous fibroids. So
we can treat submucous fibroids. We just have to make sure that we leave at least 1 centimeter clear of the fibroid up against the endometrial lining. So we still treat submucous. We won't treat if they're completely in the cavity, but submucous fibroids we still treat. We just leave a margin of 1 centimeter to allow for that heat dissipation.
Yeah, somebody's asking you, Dayo, won't GnRH analogs distort the line of cleavage at laparoscopic myomectomy?
No, we've not had that experience. It doesn't do that significantly to the point of affecting the treatment. Rather, the benefit of shrinking it is more of an advantage that we see. So we've not had that challenge of the distortion of the lining affecting the procedure significantly. The effect on the size is more of what we see, and which is beneficial to us.
Thank you. Yes, this one, last question, I think, says, there's still so many questions, but I think we answer some of them offline. I'm an anesthesiologist. Is there any radiological investigation to differentiate adenomyosis from fibroids? What I've seen sometimes is diagnosis of adenomyosis made at surgery. That is coming from a doctor who is an anesthesiologist.
Yeah, so we do, every patient that we consider for treatment gets an MRI. And most of the time you can differentiate between adenomyosis and fibroids. And a lot of the time you get a combination. We find patients who've got both adenomyosis and fibroids. But yeah, every now and again there will be a case that slips through as thought to be a fibroid and turns out to be adenomyosis. But usually you can pick it up on MRI.
Well, there's another last one, because this is interesting. Can a patient with other health issues like diabetes, IBP, HIV use HIFU in treating fibroids? Yeah.
So the other big plus factor here is that the patients don't have a general anesthetic. They only have conscious sedation. So we can treat diabetics, we can treat hypertensive patients. There's less risk of any complications there because of the conscious sedation. Obviously, they have to be controlled. it is still a form of anesthesia. So we're not going to take an uncontrolled diabetic or uncontrolled hypertensive, but it's because it's conscious sedation, there's a lot less complications. And HIV is not a problem unless they are severely immunocompromised. If they've got a CD4 count of say 10 or 15 or 20, then we're not keen to treat because we don't know what the response is going to be thereafter. Remember, that tissue is necrotic and has to be resorbed. So we're not happy to do it on patients who are severely immunocompromised.
Thank you so very much. I think we've had a wonderful time. Yes, there are some questions on Facebook about block tubes. Please, HIFU is not used for block tubes. If you have block tubes, IVF is what you should be looking at, and then you can talk to your doctor about that. So it's been so wonderful having you guys, and I'm so thrilled that we still have, even right now, people are still engaged, but we just have to go. You know, we have about 484 people still on, and that shows that this topic is dear to their hearts, and just like it is to our own hearts as well. So, but thank you so much, everybody, for being part of this, especially to our sponsors, especially to my very good friend, you know, Raymond. We're going to drag you down to Nigeria pretty soon. We just need to get the port sorted out, and then we're going to drag you here. Oh, by the way, the Chinese are coming with the machine, but I think once they leave, we're also going to drag you down here so that we can have a better cooperation, so that our patients can benefit from the experience that you've garnered over the years. Dio, thank you so much for being part of this. And all of you out there, without you, this will have not been a success. So I thank you for being part of it, and we'll see you some other time. Thank you so much. Bye.
Thank you. And
thank you.
Good luck with your machine, eh?
Right, thanks.
Lots of success with the machine when it arrives.
Okay, I'll definitely. Thanks.
See you, Raymond.
Okay. Good, Victor.